And Dr. Ömer?
Yes, Dr. Ömer is with us on the other
And
side.
Dr. Abdulaziz for accommodating our schedule.
Yeah, thank you.
Thank you, Dr. Ömer, for being with us in this seventh interventional PCI MENA conference. I already introduced you. Everybody now knows you here.
Thank you. Thank you very much. Can you see me and can you hear me?
Yes, yes.
Okay.
Everybody is listening to you.
Yeah, thank you very much, first of all, for an invitation. I'm fortunate I could make it this year. Inshallah, next year I will come and I would like to join you in Amman, inshallah. Yes, now in these DCB sessions, I have two talks. One, DCB in CTO lesions, and the other one is DCB in bifurcation lesions. The first talk will be DCB in CTO cases, sorry, calcified lesions. Yeah, sorry. So coronary calcifications, one second, yes. Coronary calcifications is we have up to 20% of the coronary interventions are challenged by the moderate to severe calcification. And of course, increased calcification is directly related with poor outcomes, especially after stent implantation, regarding acute occlusion, stent restenosis, and independent predictor of PCI failure, stent malopposition, and restenosis, TLF, and PCI complications like rupture. So what we could have if we have stents or no stents. If we have a stent after calcified lesion PCI, we could have restenosis, thrombosis, or inflammation around the metal. With the DCB, we could have elastic recoil because of the calcification. We could have negative remodeling, and also we could have chronic inflammation from wall injury. We have some challenges posed by calcification when we do DCB. The first of all, we could have impaired drug transfer because calcium may act as a physical barrier, and it will maybe limit the ability of the drug, to penetrate the vessel wall. And also one of the important issues in adequate lesion expansion, but it's also a problem for stent implantation, of course. In that case, DCB normally DCB relies on proper balloon vessel contact for drug delivery. So the balloon has to contact with the drug, with the vessel to drug delivery. And heavy calcification can cause under-expansion or incomplete contact. Of course, and also we have increased risk of type C dissection, for example, or elastic recoil. But in that case, we always do stent implantation. When we try to do DCB in calcified lesion, but we have dissection type C or type D or elastic recoil, we do stent anyway. So how can we improve DCB outcomes in calcified lesions? Of course, we have to do calcium modification first, using orbital or rotational atherectomy, cutting or scoring balloon, and also intravascular lithotripsy sometimes. Or now we have mechanical lithotripsy, which is lytics now in the market. I think imaging is also important to see, how much crack we have at the calcium, how much calcium we have. And also we have to make sure that we have optimal inflation technique. We have to ensure that prolonged and complete balloon inflation with the drug delivery. So if we have good lesion preparation, we will have better drug delivery, optimal lumen gain, lower risk of bailout stenting or acute failure, and we also but we have to know that heavily calcified lesions are difficult to treat with balloon angioplasty alone. We had better do DCB. And also, of course, we have to pay some cost for reduced drug uptake in the long term. We could have these tools for calcification preparation. So according to algorithm, after lesion preparation, if we have acceptable angiographic results, like we will have no limiting dissection. We could have dissection oftenly, but if the flow is good and there is no contrast staining. This is very important. If we have contrast staining in the dissection, we had better do stent. If we have residual stenosis less than 30, we had better do stent, or FFR is higher than 0.80, we will do a stent. If not, we will do DCB. This is our algorithm. I'd like to show you some example. This is very long lesions, lesions at the RCA. If we treat these patients with stent, I believe we have to stent from the bifurcation at the distal, and we have to stent all the way. Like we treat CTO, but it's calcified. There are lots of severe stenosis. But I think in these patients, if we treat, if we do good preparation of this vessel, we could have a chance to do actually DCB. In here we do 2.5 30 millimeter balloon and 3.5 15 at the proximal. We did balloon, a cutting balloon we use here to have less dissection. We use a lot scoring balloon before the DCB. We almost routine use now scoring balloon or cutting balloon before the DCB, and we have less dissection. We prepared it. We did. You see, it's a really good classification. We just opened that classification by 4O cutting balloon, and after 4O balloon, we have a forced NC balloon. This is a very strong balloon, like OPN, and we will open it, and then after that, this is the result. We like the result. I think we believe that we could do this DCB, and we did DCB from the distal. Again, we did cutting balloon at the distal. Now we are doing DCB 3 or 30 distal, 4 or 49 proximal. And then this is the result after 2 DCBs. I think this result is acceptable for DCB. And then we had a 6 months follow-up of this patient, and we have still nice flow. Of course, we have some plaques, but the flow is very good. We are very happy about the result. I want to show you another case. This is RCA LADCX, very calcified lesions. We use this patient orbital atherectomy as well as AVL. This is right coronary. We have very calcified lesion at the right ostium, you see. And of course, I will show that we have a very tight circular calcification at the ostium. This kind of, RCA osteal calcifications are very, very tough. Very difficult to crack this calcium. We have to be very careful. Otherwise, we could have underexpanded stent, and it will be bigger. You see, we have a big nodule here at the ostium. We did this. We did here orbital atherectomy first, and this is before. You see the before, but now this is after orbital atherectomy. We have a nice lumen after orbital atherectomy, but of course it's not enough. We have to do post dilatation more, and C balloon, and we have type A dissection. This is fine. This is very good. So, and after type A dissection, we believe that this is okay, and we applied DCB here. And this is post DCB. Still, we have a small type A dissection, which is very, very fine. This is no worries at all for DCB. And for left system, you see we have proximal LAD lesion, and here we have actually CX ostial lesion as well. And ostial lesion is CX is very tight. In here again, we use orbital atherectomy, which was the same one. Again, we have very tight lesion at the ostium of the CX, like you see here, and this is the LAD, but we have very tight lesion at the ostium. This is LAD run. We have circular calcification. Lumen is fine at this level, but certain level we have again tight lesion. And then how we treat this? We did AVL. We did AVL to LAD all the way, and then we did orbital atherectomy to CX. Let's see the result after orbital atherectomy. This is before and this is after. Again, we have a nice lumen after orbital atherectomy. I like to see this. You know, we have a nice lumen now, but of course not enough. We have to do some preparation. After preparation, we did long DCB to CX and another DCB to LAD. We did, you know, minimal kissing balloon here. Normally we don't do that much kissing balloon at the bifurcation because of the calcification risk, but this is left main and we have minimal kissing, and we believe that this is safe for this left main. And after this final result, we have a nice result. Actually, it's like stent-like result, right? So I think this is very for us, it's you know, encourageable to leave it only DCB because we don't have that much dissection. This is LAD system. The last case for calcific lesion, this is also LAD calcified lesion. Proximally, we have a very calcified lesion. You see, this is we have stenosis and tight lesions all the way. We wire it, and then we did here 2525 balloon just to touch the lesions, and of course it's very calcified lesion, and there is dog bone effect. Even with the 2.5 balloon, this is bigger balloon, but the same. And then we did IOS. IOS tell us severe calcification. We did this just before IOS. So we are able to cross out IOS, but you see calcification all the way. And this calcification is almost circular. Most of the time, larger than 275 degrees. And after these small balloons, but we have tight lesions. We didn't touch, you know, lesions actually. This is 358 NC, but it didn't expand. This one didn't expand, and this still, you see that there is an under expanded balloon here. So, and then we couldn't open with this NC balloon. And then you see this after NC. And then we had used here mechanical IVL, which is lytics device. This is you see this device. We have a hemispheric metal to increase the atmosphere harsh contact method. And then with this balloon, we have extreme atmosphere like 60, 70, 80 atmosphere on the balloon. Now you see there is still some, we have to wait a little bit, and then after for a while we have expansion of that level. And then after lytics with this, and then this is another run with IVL, another run with IVL, the same IVL, and then this is the result after IVL and the NC balloon. I think now we have good opening. We have to decide which kind of treatment we can do. We did here DCB 3535 and 2530 for the side branch diagonal. And then this is final result. We have, again, diagonal looks not bad. So take-home messages: calcified lesions need tailored preparation for DCB success, and use imaging to access and guide preparation strategy is very important. And DCB is viable if T3 flow. If we have a T3 flow less than 30% stenosis, and if there is no major dissection. Okay, thank you very much for your attention for the first talk.
Thank you, Dr. Ömer, for this interesting techniques and game-changing concept. Let's move to the next lecture, and we'll defer our questions to at the end of the session.
Yes, thank you. So the next talk will be DCB in bifurcation lesion. Can we leave less metal behind in the bifurcation? So the last consensus documents from EBC published like 2 years back, and then they say that bifurcation PCI is not just about opening a vessel. We have to treat lesion, but also we have to preserve side branch. We have to respect bifurcation geometry, and also it's good to avoid unnecessary metal burden. So why we should consider less metal in selected bifurcations? In bifurcation PCI, every additional layer of metal comes at the cost of geometry, access, and long-term flexibility.
Dr. Göktekin, we don't see the slides. Can you share the slides with us?
I will, 1 minute, I will share it again then. I think, yeah. Oh, sorry. Okay. Can you see it now?
Yes, of course.
Oh, okay. Okay, then let's continue from here. So why consider less metal in selected bifurcations? I think we could avoid multiple metal layers. We can preserve carina and side branch access. Or we can reduce the distortion, overlap, fracture, malapposition risk, and keep feature options also options is open. Especially at the side branch osteum, every additional implant changes geometry. DCB is attractive because it delivers antipolarity therapy without any adding another permanent layer. So basically, we have two key strategies. The first is DCB only approach, and the second is hybrid approach. The DS plus DCB for the side branch, mostly. I think it's a logical middle ground. Stent the main branch, treat the side branch without another metal layer or structure. So we can secure main branch with DS, but we can treat side branch biologically. In that case, we avoid committing to a second stent, and also, of course, we can preserve feature access. So DS is for structure, DCB for drug delivery. This is hybrid approach actually, and this is very promising. We have hybrid study. Hybrid study published 3 years back is a sub study and tell us hybrid strategy is very safe. In that series they treated 50 patients and only one patient has TLF in that series, and they stent main artery and they did the drug cortical balloon the side branch, and it worked very well. And also there is another observational left main study. This is also DS left main and the DCB side branch, and they compare it with the two DS techniques. And we have late lumen loss at the side branch without penalty in clinical events in that patient, in that study. In the MACE, there is no significant difference. This is the study I mentioned. I think for the DCB only strategy, we need a more stronger data. And now EBC has a study called EBC DCB, and now they randomize two arms. First arm the DS and the second arm DCB only. So we will see the result. It's going on, but it will help us a lot. So when does leaving less metal make sense, especially in anatomic view? If we have in patients with non-left main, true but non-complex bifurcation, I think it's good indication for DCB only or less metal. Side branch worth preserving. In case of side branch worth preserving, and also Sometimes a side branch is not clearly demanding a stent, but sometimes side branch needs a stent. In that case, still we can do DCB, but we might have a also stent implantation needs. So in the same as here, we have to do good preparation, good lesion preparation. We have to have T3 flow and no flow limiting. And the goal is deliver drug without extrametal layer. So in here, there is a guideline by ACC. They published it recently and last year. So if you do, they publish it, this algorithm. They say that when you treat true bifurcation with the DCB, they say optimal lesion preparation of the main branch and the side branch. So they do it. They suggest it with NCB scoring, cutting, atherectomy, or lithotripsy. Okay. In here, I am not agree with this algorithm. That's why we do it differently. I will explain it and why. But they say, okay, do lesion preparation at the beginning, main and side branch, and after main preparation, after main and side branch preparation, if we have acceptable results, angiographic results, we can do DCB. Okay, acceptable main branch and side branch result, we can do DCB in both. If we have acceptable main branch and suboptimal side branch, we can do DCB or DS on main branch, but provisional side branch stenting. Okay, so if we have a subintimal angiographic result, of the side branch, then they suggest suboptimal main branch, and if we have suboptimal main branch and acceptable side branch results, we can do DS on main branch, DCB on side branch. If we have suboptimal main branch and side branch result, we could do DS on main branch and provisional side branch. Anyway, so I suggest this in my clinical practice because this is very important. So I have a bifurcation lesion and I want to treat DCB only, all right? So in that case, what we do optimal lesion preparation of main branch first. This is very important. Okay, we have to make sure we could treat the main branch with DCB. If we put a stent main branch, we never touch side branch before. We never do side branch lesion preparation because if we do lesion preparation simultaneously after having main branch stenting, when we try to recross to do provisional KISS or to do DCB side branch, we have a high risk to go subintimal space in the side branch. This is very important. So what we do, we just dilate main branch. We do optimal lesion preparation in the main branch. If we have optimal after optimal lesion preparation, if we have acceptable angiographic result of the main branch, then we think that okay, we will do DCB. We are okay with DCB for the main branch. Let's go to side branch, and then before doing DCB, then we do preparation of the side branch. If the side branch is acceptable, this is very good. Then I can do DCB only for both vessels. So in that case, we do DCB main artery. We do DCB side branch. This is I think the best the option for me. If I have optimal main preparation but suboptimal side branch, then again we can do DCB main branch. But in that case, we may do stent from left main to side branch and post dilate. In that case, I have to have some risk for recrossing of the main branch, but the dissection risk is less in the main branch because main branch is bigger than side branch. So wire-based dissection risk is less in the main branch. So I do recross and then we do KISS with the DS and then DCB. If we have a suboptimal of the main artery. So we didn't touch a side branch. We tried to do a preparation main branch, but the result is not optimal. All right, we have dissection, we have a recoil, everything, and then we just treat main branch with DCB. Then we are hoping to do hybrid, right? After main branch stenting, we rewire side branch, a lesion preparation. If we like the lesion preparation, if the result is optimal, then we do DCB side branch, and then we do KISS with that DCB balloon, and then NC balloon in the stent. This is our approach when we try to do DCB. I will show you a couple of cases very fastly. This is case one. This is has patient angina. We treat this patient's LAD diagonal. He didn't accept CABG operation. This is his lesions, spider view, epicaudal view. What do you think? What is this? This is dissection? It looks like dissection, but it's not actually. This is that branch. I was a little bit confused, but then I see this is a branch, and that branch comes here. It looks like a dissection, a guiding induced dissection, but it's not. And so I wire two branches and Sani, Feza. So we did preparation. We use NC balloons, and here we use also, you have seen 3 dots here. We use a lot of scoring balloon. As I told you, this after we do scoring balloon cup. First, as I told you, first we treat LAD, right? We have to make sure LAD doesn't need any stand, and then we can do side branch. This is main branch. This is after preparation. We are okay with that. We have some kind of dissection, but there is no flow limitation. More importantly, there is no any contrast stain in this dissection. This is very, very benign. This is very good for DCB. And then after seeing this, we treat side branches. We had lesion preparation, and then we did DCB. This is DCB LAD, and we did also this one was the DCB for the diagonal, DCB for the main artery. So this is, you see, after preparation, everything is good. This is main artery, DCB. This is the final result. Looks not bad, but after 6 months, we still have nice result. We don't have any metal here now. We are happy about the result, actually. This is another case, again, LAD diagonal 1 lesion. This is a long lesion. So we have one lesion, tight lesion here, one after diagonal. We did preparation, distal and proximal. And then we see the result. So we think that, okay, we have hope for DCB. And this is a very calcified lesion you have seen here, right? Very calcified lesion. And then we work more. And the side branch preparation, because we are happy with the first main branch, and this is DCB. And then after DCB, side branch, DCB, preparation, and DCB, of course. This is final result. Especially proximal looks very good. And after 6 months, we have a great result. It's like stent-like lesion, I think. Stent-like result. We have still some 50% stenosis, but it's very calcified part. I'm not sure how stent works here. Very calcified nodule we have. The last case, this is we did hybrid approach here, left main approach is PCI. This looks like a true bifurcation. Distal left main. And then here we did the hybrid approach, provisional. So we put one, but of course we did preparation of LED first, and then we did not last dilatation and stenting. We did the stent, and then recross the CX, and we did KISS. But the side branch we treat with DCB. Final result was good. So LED stent, CX was DCB. Okay, thank you very much for your attention.
Thank you, Professor Göktekin, for this nice presentation and interesting cases. Of course, not leaving metal behind means better vessel vascular physiology, better surgical future for patients, and less need for dual antiplatelet therapy. Let's open the discussion now. Dr. Raed.
Dr. Ömer, how are you? Dr. Raed,
fine, right. How are you?
I'm fine, thank you. I know that you are a CTO operator, and nowadays, actually, we are doing DCBs for lots of our CTOs. Last week, I did 3 CTOs, only I used DCB. What I want to ask you about many things. First of all, as you said, we need lesion preparation. And this lesion preparation, we need to have a controlled dissection. And to minimize the risk of dissection, we use the NC balloon, the small diameter one, just to cross the scoring balloon, and then to do the controlled dissection. So like this, you elaborate for 2 things, that the dissection will not be not controlled, type B or C. And the second thing, you crack the calcium, if there is calcium, and allow the drug to elute inside the vessel. This is one strategy. I don't know if you agree with this or you do it this way. And the second question, in the CTO, we have problem with the intravascular hematoma. You talk about the dissection, the calcification, and the recoil, and the residual stenosis. How about intravascular hematoma? Especially when we go with ADR or RDR and these approaches. Do you have different strategy for DCB or DS?
Okay, thank you, Ranch. It's a very good question. First of all, preparation is extremely important. And these days, what I do, I'm as you do, I'm doing lots of DCB, and we have actually great results. We do now systematically 6 months follow-up of angio follow-up of our patients, and we are very happy about the result. To be honest with you, so for lesion preparation, we do now routinely scoring balloon, but we have now in the market 3 wires scoring balloon, right? So I like them a lot because those scoring balloon doesn't do that much dissection. They open artery nicely. Most of the time, I have stent-like result after using this kind of scoring balloon, right? So I think everyone now these days can try if they have stent-like lesion, result after balloon dilatation. If they have stent-like lesion, I think everybody can try DCB, even in main arteries. I mean, major arteries like RCA, CX, or LED. Of course, if they have the dissection, they can use DS, because many of our colleagues, they are not comfortable when they have dissection. I am agree with that. It's okay. But if they have stent-like result, they can do DCB rather than stent, because the results are good. Yeah, we have very less stenosis actually. So regarding hematoma, if we have hematoma is something different. Yeah, we have a dissection, but then we have subintimal bleeding, and then that hematoma reduce the size lumen of the vessel and make stenosis. In that case, cutting balloon helps a lot. we do cutting balloon. Most of the time, cutting balloon, treat this hematoma most of the time. If after hematoma, if we have a good result, not that much big flap, we do DCB. Other things to say, especially I know that you do lots of CTO DCB. In CTO, sometimes you have big dissections. If you inflate your balloon like 5 minutes, 6 minutes, like we do in peripheral below the knee, after 5 minutes, 6 minutes, mostly we heal, we seal this dissection. So especially for CTO, patients can tolerate very well. If you inflate 5 minutes, 6 minutes, patient feel nothing because it was already CTO. So it's a new era, but I'm one of the believer. I don't think that the DCB is much better than DS. I'm not sure. For short-term result for 6 months, 1 year, but in the long term, maybe DCB could better because every year stents has 2% MACE rate. After implantation, there is no plateau. Every year we have 2%. So with DCB we can have advantage. Maybe I don't know. We will see.
Dr. Ayman Hamdan, do you want to?
Thank you, Dr. Ömer. I don't know if the jury is out now. We have a meta-analysis of more than 800 patients that really showed comparable MACE between DCP and stenting. We know that the coronaries, they like to twist and bend, and the DCB leave no stent behind means we will not have instant restenosis. We'll get rid of the stent thrombosis. DCB has a better drug delivery. It will promote positive remodeling. It will prevent the caging of the coronaries, which is thought to increase the restenosis. It will also promote vascular healing and restore endothelial function. Do you think we are, and especially when these tough cases, STEMI and CTOs, do you think we are going to be coming to the era where stent will be just a bailout technique and DCB will be the name of the game?
Yes, I think so. Why not? Why not? We can, of course. I believe that we can go there. We can go there. That's very good. I think opinion. I like this. Yeah, we can do this in next future. Let's see. It will take time because we need some data, randomized data. But we could have it. I like to use DCB. I like to. Of course, we do lots of stenting before. Years for years we do it, and results were okay. But stent is a stent, right? It's metal, and also psychologically, I think it's affect to patients. Patients, they are very happy if we don't put anything in their coronary. I tell you, and they feel more comfortable. They feel that like some patients feel that they are sick now. They have stents. They can't do this. They can't do that. This is also a psychological issue for some patients. They are more happy. They are more willing to do exercise and everything because they think that they can prevent something. They are good. They have nothing in their heart. I think that's also advantage for some patients.
Yes.
Well, thank you very much for this informative lecture. Actually, so I have a couple of technical questions. Do you think it's necessary to rely on intravascular imaging, especially if you're dealing with large vessels? Well, personally, what I did, I rely only on angiography if it is a small vessel, and if it is large, I need to be sure I adequately crack that calcium. So I use intravascular imaging. Do you agree with this or not? Number two, it's a little bit technical in bifurcation. Do you think it's necessary to end up with a pot after using a drug-coated balloon in the side branch? And of course, from your experience, what do you think the most reason of lesion failure with using the drug-coated balloon? And thank you very much.
Okay, very good question. Thank you very much. So the first question was using IVOS, yeah? So Of course, for small branches, everybody use DCB. You know, it's very nice to use DCB. I think it's wrong to use 2.5 stent, right? 2.5 stent has a high restenosis risk, especially when I treat patients. If I put 3.5 or larger stent, I am okay. I know that I have less restenosis rate. But if I put 3.0, less than 3.0, I always think that, oh, I may have, you know, restenosis because of the size of the stent, basically. For a small branch, I don't think we need to use a stent anyway, and then we can do DCB. IOS, yes, I don't think it's important to use for small branches, as you mentioned. For large, if I have a calcification, I most of the time do IOS, right? So I want to see the anatomy, I want to see the lesions. Which kind of calcification I have, which kind of, you know, lesion preparation I had to do. So IOS helps a lot for large calcified lesion. But for DCB, I don't think. Of course, for calcifications, yes, the same. But for non-calcified, if you don't have a big severe calcifications, I don't think IOS could help DCB as much as stent stent implantation, you know, because in IOS, in this, if you implant stent, we have to have larger lumen area. We have to push limit. We have to do you know, post dilatation with bigger balloon, right? To have less restenosis. But for DCB, we don't have to do it because even you know, even 1-to-1 is okay for DCB. When you do IOS maybe you know needs you using bigger balloon. That bigger balloon may you know lead dissection, because if you use bigger balloon, you have a risk of more dissection. So in summary, for routine DCB, I don't use IOS. For calcified lesion, I definitely use IOS when I do use DCB. For stent, for sure, we use, of course, IOS in calcified lesion. For non-calcified lesion, I don't use IOS routinely. If I need to see something, yes, I use. But for evaluation of the result of DCB, I don't use it. DCB is very forgiving work. Okay, very forgiving. You don't mind. You know, in Turkey, for example, I have lots of in peripheral. I have lots of underexpanded stent. They don't do they even now to 2026. They don't do preparation. So there are lots of direct stenting in everywhere in Turkey. Still, you know, we keep saying that do preparation, do NC balloon, and then put stent, but still they just put a stent, right? And then they have, of course, acute occlusion and restenosis, lots of. So at least I'm happy that those guys, if we you know, teach them to use DCB, there will be no harm, nothing. They will do DCB. If there's a restenosis, that's another issue. But I think in that way also, using DCB is, I think, could be more helpful for the routine practice, I mean say, because not everybody like us, they don't do good preparation, they don't do good post-dilatation. This is reality, right? I'm sure you will be the same. I have lots of CDs. I'm very sorry about those operators. They are not doing the job. But for DCB, it's very forgiving. That's also an advantage for me.
Yalla, short question by Dr. Mander.
Dr. Ömer, thank you for your nice talk. One question, what's your preferable ratio, balloon to vessel ratio?
1-to-1. Not less than
For the
1.
side branch and main branch, both?
Yes, the same, yes. I mean, angiographically, because as you know, angiographically, always we see, you know, 0.5 smaller anyway.
Okay, thank you, everybody. Thank you, Dr. Göktekin, for this nice presentations and rich discussion. Thank you, everybody.
Thank you very much for the invitation again. Thank you so much.
Thank
Salam
you. Move to the next session على طول.
Yeah. Let's move to the next session. Thank you, everybody. Hey, Dr. Mahmoud.
يعني 10 minutes behind schedule.